My name is Luis Malpica. I'm actually an oncologist trained originally in Peru. I did med school there as well as residence in infectious diseases, but then I get passionate about oncology. So I did my internal medicine residency again in Miami, and then my fellowship in the University of North Carolina in Chapel Hill. Since September 2020, I'm an assistant professor at the University of Texas MD Anderson, and I work in the T-cell lymphoma program at my institution. One of the challenges, and I will speak both from in the United States as well as outside overseas, since my research focus in people from color treated in Latin America as well. In the United States, one of the challenge which we see very often is that uh, there is many times lack of resources for patients and as well as lack of literacy, which has a lot to do with the disparities we see in general. And many people will argue that a lot of those disparities are driven, of course, because of money. But every time we are learning more and more that biology also changes depending on your color. And the other thing that we see as a challenge is um, if if you have a clear skin, it's easy for you to know what's going on. But in people from color, it's sometimes very hard to diagnose what's going on in the skin because you cannot differentiate what's happening in there, other than people telling you that they have an allergy in the skin for many years. So it is well described that people from color sometimes they are diagnosed later on their life because those are under recognized by community doctors, and it has nothing to do with that. It's just that it's biologically again is different and very challenging because of the way it presents. And outside from the United States, I'll say that the main issue we face in Latin America is the access to novel therapies. But that's a thing that happens pretty much everywhere in the Hispanic community that doesn't live in the United States. So there are several barriers that the Latino community faces. It's true that one of those is basically the financial burden that they could sometimes experience. It's less to say that many of these patients are immigrants. They are either uninsured or underinsured. And one of the things about treatment of cutaneous lymphomas is that this is a chronic disease. Yeah, it's the same as saying that you have hypertension, you have diabetes. It's something that you many times cannot cure, but most of the time you can provide quality of life, and you can keep the disease under control for many years. And the survival in general is really good. Most of the time, what we're seeking is to improve the symptoms, to make patients feel, uh, I will say how the way they phrase it, not miserable throughout the course of their disease. So because of that, a lot of the Latino community, given that this is a rare disease, the access to therapy could be challenging. I know there are programs that help these people, and in Houston, for example, we do get consults from community hospital to MD Anderson to see how we can assist them, and I provide insights and recommendations. For example, the fellows in MD Anderson works in LBJ Hospital, which is a community hospital, and they many times have me a reference for management of these patients. But at the end, ultimately, it all comes to how affordable could be for the patients to get on treatment. But the good thing is that there are programs that are willing to help them. But this is a challenge that I don't think is just particularly faced for CTCL or cutaneous lymphomas. I think in general for rare diseases, and that's the challenge. Rare diseases tends to be a little bit of a challenge for people that treat them, not only in the area of lymphoma, for any rare diseases really in general. So there is some cutaneous lymphoma that are driven by viruses. One of these viruses I study is called HTLV1, which stands for the human T-cell lymphotropic virus type 1. It's quite endemic in the Caribbean and in Latin America. It's transmitted similar to HIV, meaning like sexual intercourse, breastfeeding, as well as blood transfusion or needle sharing, and people that is that use drugs intravenously. And this virus is associated to a specific type of T-cell lymphoma, which main manifestation is in the skin. So this cutaneous T-cell lymphoma is a type of T-cell lymphoma, presents very commonly in the Latin American community or the Hispanic community, but you must have the virus. To the point that these patients sometimes or many times are diagnosed as mycosis fungoides and sometimes as Sézary syndrome, which is a form of cutaneous T-cell lymphoma, until you ask them where they're from, and then you test them for the virus. To the point that in the United States, most of the academic centers, to not say all the academic centers, test for HTLV1 in any patient with cutaneous T-cell lymphoma. That has become a standard of care because that's the broad differential. Now, why it's important to do that exclusion, or why it's important to look into different cutaneous T-cell lymphomas? Because some patients can present as patches, just a patch lesion. Some of them can present like a micropapules, like very tiny nodules. But then in ATLL, you can have adult T-cell leukemia lymphoma, which is the disease that produces this virus. They can have tumors in the skin. We call it a nodular tumor presentation. And that's been so aggressive that now we have grouped that entity as primary cutaneous tumoral disease, which is not something you can see mycosis fungoides, but more frequently this type of disease. Yes, there is difference. One that can be grouped as environmental, meaning like what is the patient has been exposed to. Many of the cutaneous T-cell lymphoma patients tell you that they have worked many times in the farming community. There is a lot of farmers. Most of the cutaneous lymphoma we see in Hispanics are from farmers, or they have worked with chemicals their entire life. Even though we don't know exactly, there is a huge correlation. Epidemiologically, you can see that as a common risk factor. There is ongoing studies on people that I work with in different foundations, like the LRF or the LLS, that conduct research looking at these factors. And the other piece of presentation is that we tend to see some patients with blood involvement. I'll say that in the United States, more patients present with a lot of blood involvement, what in the Latin American community, you usually see more the skin being the main compartment to be compromised, while here we see more of the blood being involved. All this, again, is based on observations. I wouldn't say that we have necessarily conducted that in a prospective way, which is the right way to do it, just looking at patients from the time they're being seen till they die from the disease or something else. And that's what my research is about, is we're creating a prospective cohort of patients with T-cell lymphomas that they sign a consent from the time of diagnosis, and we follow them over time to see which features or epidemiological features could influence not only their outcome, but the quality of life, as well as the development of any other complications from the treatment or for the disease itself. Historically, when someone looks at the novel way to manage lymphomas, which is basically based on using a genomic testing, the molecular part of the disease, we're decades behind in Latin America. And this personalized treatment has a lot to do with the way we are learning more about lymphoma biology. And a lot of that, of course, in cutaneous T-cell lymphoma, the field has evolved tremendously in recent years. Why is that important to know? Because when we look, unfortunately, to many of the biggest studies in cutaneous T-cell lymphomas, there is a paucity and lack of data on what is the race and ethnicity of the patient that are being sequenced, or that the tumors being sequenced. For instance, there was a publication in 2019 in Nature Genetics. In general, in cancer, the amount of Hispanic or Latino patients being reported in the studies were around 20%. However, in non-Hodgkin lymphoma, cutaneous T-cell lymphoma is a non-Hodgkin lymphoma, there were 0 studies reporting about race and ethnicity, which means that they sequence all this patient, but they never said where is the race or ethnicity of this patient that have been sequenced. And why is that important? Because we know diseases differ by geographic places. For instance, a blood disorder called thalassemia, that's frequent in the Eastern world, like in Greece and some other countries, and it's very infrequent in the United States, unless that you are descendant from this or have an ancestry from European ancestries. Same with sickle cell disease. It's mainly, unfortunately, affecting the African American population. So we know there are certain blood disorders that are particular to certain ethnicities. So the same thing applies for genomics. Genomics, the genes are different. That's why I have brown eyes. That's why you have blue eyes, because our genes are programmed to do certain things. But the same thing stands for cancer. That's what, again, just an example in cancer, Ashkenazi descendants, they have more likelihood of having a BRCA mutation than we do, because that's how genomically they have evolved over time. And that's what has happened throughout the years and decades in these populations. So because of the lack of genomic data in Hispanic community, is that MD Anderson and myself developed this initiative called the ELA project, which stands for Epidemiology of Lymphomas in Latin America. So what is the ELA project? The ELA project is a project in which we prospectively enroll patients with any kind of lymphoma, and we follow those patients prospectively. We see these patients from the time of diagnosis, and we follow them at the first year every 6 months, and thereafter every year. And we look at the outcomes from the disease, from the treatment, but also which other factors the affect their outcome that perhaps may be or not disease related. For instance, when you present a data, or when I used to present data to big congresses, many of the criticism I got is, well, Luis, you don't have this technology in Peru. And for many, many years, there's been this stigma that because you lack resources, that's why your outcomes are worse. Well, we give a big of a shot in this American Society of Hematology meeting in New Jersey, I'm sorry, in New Orleans this past year, in which we show that in any kind of the world, any place in the world, if you have this disease called adult T-cell leukemia lymphoma, your outcome is worse. And we included patients from the United States, we included patients from the Caribbean, from Latin America, and from Japan. We have two developed countries and all the other countries and developing countries, and the outcome was absolutely detrimental and the worst in all these populations, which says that the biology of the disease plays a huge role in the outcomes of the patients as well, and that there is an unmet need to improve that. So the first fall, as I said, is to learn more about these rare diseases, to study them in a place in which they are endemic, because we cannot go and study these diseases in the US knowing that these cases may be seen better in other places. And the third one is introducing genomics and molecular studies to these ethnicities and races to understand biology better. But what about the rare lymphomas? And the important thing when you use rare is that if you want to allocate resources, you're not talking about thousands of patients. You're talking about 20, you're talking about 30 patients, a number that you can work with if you have a budget that you can accommodate them. So we partnered with the Lymphoma Research Foundation and the Leukemia Lymphoma Society to develop and expand clinical trials that are novel in our institutions to the community in Texas. So to achieve that, we actually have written a grant and have received funding to get all these innovative trials that are initiated by investigators like myself and others to the community, so that way these patients can get enrolled, and we can and our, I would say, our enrollment of these patients with rare diseases increases by allocating funds and getting the patients where they actually live, which is in the community. Because, getting access care, if they want to be treated in Houston, they have many times to look for hotels, transportation, caregiver support, and many times they cannot do it because all they have to live is just the monthly payments they get from their employer. And many times they even sacrifice that insurance because they have to come back and forth and they lose their job. So we're bringing these novel clinical trials and developments to the community through funds. So that's another way, for example, to one, increase diversity in clinical trials, because that's what we're doing indirectly. We're increasing diversity by enrolling patients from different ethnic backgrounds and different geographic locations. And second is hopefully being able to make cancer history, as the term we use, but also in rare lymphomas and rare diseases. This is a rare disease. So I would always advise my colleagues in that community to seek for a second opinion. I think that in a lifetime, and there is studies about that, a community physician looking at cutaneous T-cell lymphomas, they could see as much as one case per year, or sometimes even one case in their career. That makes them sometimes not, I don't think that incapable, but non-comfortable with certain treatments that sometimes have certain side effects. For instance, when we recommend people to get mogamulizumab, which is a drug that we commonly use in cutaneous lymphomas, sometimes the challenge they face is first, they don't know how to get the drug approved. And many times if they get it approved, they don't know the side effects that many times is something that doesn't necessarily lead to stop the drug, but instead to looking into the differential. This is progression, or this is just basically a side effect from the drug that could be managed just by holding the drug for a few days, or using creams, or something that could be managed. So my first tip of advice, regardless of the color or where you're located, is it would be always good, or wouldn't be bad, to seek for a second opinion in an academic center, in a center that has the capability and experience to co-manage. Because the patient, again, as I said, there's a lot of barriers to getting patients to big academic centers because they are located in usually big cities, but to co-manage them and we communicate each other about that. That's, for example, something that I practice in my clinic. I have a huge list of telephone of all people in the community that I always tell them, just to talk to me if there is any challenges you face. Now, going into people from color is many times with them, the challenge again is that how do you stage the disease? How do you know patients are responding and not responding? Because unfortunately, one of the real things is that it's difficult to know what's happening in people with color when you're managing skin cancers, specifically cutaneous T-cell lymphoma. So my recommendation will ultimately go to the same, to have two people, one managing locally and one managing in an academic center, that can assess the patient over time, especially if there is a concern that the patient is getting more symptomatic despite everything you're doing. And what we do usually is that most of the time patients go to their community doctors every 2 or 3 months, and they see us once a year. And that way we can have a multidisciplinary management in which we know what's happening over time to that patient. Another thing that I would recommend is to, even though it takes a lot of time from people in the community, for which MD Anderson, for example, has the resources to do, is during their first meeting, the patient usually see that the one day they are there, they see a dermatologist, they see a radiation oncologist, they see our social worker, they see a transplanter, and they see a lymphoma physician. So only there, I'm telling you, there is 5 people on board in their care the same day the patient comes. So the question sometimes comes like, can they have the same care, looking at the same amount of people involved in their care in the community? And the answer is many times it's very challenging for them to do that. So another piece of advice will be that one, to have always a multidisciplinary team involved in this patient's care, because sometimes what is flagged as patient non-compliance is usually not related to non-compliant. It's just that patient cannot just commit because of the treatment, because of the transportation. So, and that's what the social worker, for example, gets very, very involved from these patients, and they are always involved in these patients. And the last thing I would say that I would recommend to providers in patients with color is always, if possible, if there is any concerns on these patients in regards to treatment, or maybe the patient is not following the directions, to make sure that they are understanding. Many of the people, or Latino people, for example, that comes to the United States, they lack literacy about what's going on, especially in rare diseases. And also because, at least in the United States, and that's something that we're trying to change with partnership with the Lymphoma Research Foundation, there is not much things in Spanish that, for example, patients can read and trying to understand. For example, with Team Fraley, we have been able to get this information out in Spanish, for example, for mogamulizumab. And that has definitely helped the patients that I treat that are Spanish speakers to provide information that are within the language they speak. And many times also it's important to remember that sometimes this patient also do not really know how to read. and you have to provide audiovisual things that can help them. So my summary of this is there is many factors that affect the patient's care, and one of those could be the fact that the patient just doesn't understand what's going on. So a big piece of advice for me is if you are noticing that what someone is expecting to happen as an outcome is not happening or not being delivered, to make sure also that the patient is on board, that he understands that what the process is being and what the goal is, because it's important for them to set up goals so that way they know how things should be looking at. And knowing that this disease many times requires multiple treatment options in order to lead to a very good outcome. Sometimes patients, it takes them like 3 or 4 treatments to just start seeing that things are changing. So that could be very challenging with someone, and I'm saying this as an Hispanic descendant, that someone for us is difficult to understand that we are in a big country, we are in the #1 world cancer center, and things are not changing. But it's not that. It's just the biology of the disease is very challenging. So adult T-cell leukemia lymphoma is perhaps the first cancer in the blood that was linked to a virus. It was Dr. Gallo in the NIH when it was actually even before HIV was discovered as a virus producing a disease. HCLV1 actually was named type 1 because it was the first retrovirus linked to produce cancer, and specifically hematologic cancer. So adult T-cell leukemia lymphoma is a disease that is unfortunately lethal. We call it deadly lymphoma as well, in which patients that are diagnosed, they usually don't live longer than 4 to 10 months, which is the average. This disease is basically divided in 4 subtypes, and I'm not going to go that in detail, but all I can say is it's called adult T-cell leukemia lymphoma, or ATLL, because it either can present as a leukemia, meaning just purely in the blood, or as a lymphoma, meaning just like tumors in the neck or any other place that can produce symptoms like pain and things like that. Why is important for me to research this disease? The first one is because it's caused by a virus, and you know what a virus can make. Just remember about the pandemic, something that no one wants to remember, but we knew that virus can produce this. So no one was surprised that a virus produced such a detrimental a public health issue, but not only that, also to the economy of the country. I mean, many countries shut down. Many countries did a lot of things to trying to prevent this from spreading because it was compromising not only the population's health, but also the economy of the countries. So that's one of the things. This is caused by a virus. And this virus gets into the human genome of the patients, and it produces a lot of issues within the human DNA that then leads into this cancer. So that was one of my first interest. The second interest is that as I was mentioning previously, we ran this big study of 873 patients with ATLL. And what we find out is that the disease is aggressive regardless in which geographic area you live. Even if you live in such a developed country like the United States or Japan, or in such an undeveloped country or developing country such as Peru or Chile or Ecuador, it doesn't matter where you live in the world, that disease will kill you very fast, despite of you receiving transplant, despite of you receiving the most advanced care you have. So the second thing about my interest about this disease is that it's a lethal disease for which there are novel treatments that needs to be developed and needs to be performed. So because of that, and because the rarity of the disease, we see around, I would say, optimistically 10 to 15 cases of this disease in the United States. And we're talking about millions of people living in the United States. So that talks about the rarity of the disease. And most importantly is that most of the time I get asked about how to manage these patients because not many people have seen them, because I have the privilege to work with this patient population. So back in 2020, when I started my faculty position, I had a very beloved patient who unfortunately died despite having received chemotherapy in a first line, chemotherapy in a second line, having received CAR T cells, 2 different CAR T cells. Okay, so we're talking about technologies that are not available anywhere else, 2 different CAR T cells, and other investigational agents. She received almost 5 lines of therapy. She was in her 50s and never made it to transplant. because the disease continued to progress. So her daughter lived through that. And then talking to her and talking about how that, on the other caveat, I guess, to this is that when I was talking to her daughter, I asked, the first question I asked her when I met her was, were you tested for this virus? And she clearly said, no one ever told me I need to be tested for the virus. So my next thing for her was, well, you must be tested for the virus. And that's a common practice in Peru, where we see HTLV1. That's a common practice, actually, surprisingly, in London, in the UK, where you actually have a program for these patients because they treat many of these patients. Or France. France has, because they have um, islands, or I would say part of the countries. There's French-speaking islands in the Caribbean. Many of these patients that live in the Caribbean when the virus is endemic, they travel to France to get their care. So they're familiar with the disease and they know family needs to be tested for the virus. So when I asked her, have you been tested for the virus? She was shocked that she could potentially follow the same path. Unfortunately, her mom has followed. She is not tested and she doesn't know that she has the virus. So then that raised the concern for her of, I mean, why are we not creating awareness, which is was my concern too. So that's when this ATLL support group started. So it all came based on a case that I saw in the hospital, despite having done it multiple times and seeing multiple of these patients, and then start developing this group. Ever since then, we have 50 plus members. Again, to be a rare disease, we have to be mindful that 50, maybe for a Facebook group, is not that much. But if I tell you that are 10 cases per year in the United States, 50 probably is exaggerating, maybe 5 years already of research, and then the group has been only in life for a year. So that speaks about, and there's been a lot of questions, like the question I was asking you. People ask there, I've been diagnosed with this, what are the next steps? We've been able to send out clinical trials that could be a good fit for them, because for rare diseases, clinical trials is going to be one of the best options aside from the standard of care. We have been able to provide educational material both in English and Spanish. And we have been able also to provide care to their families, telling them, be tested for the virus. And if you're positive for the virus, have someone in your family, uh, in your care, your health care, to look at for any signs or symptoms, because this is a blood disorder. So many times the first symptoms comes out in the blood. There is no specific screening that can predict when the disease can happen. But if you have at least someone to monitor, make sure that there is no nodes or there is no blood involvement, because the malignant cells can be seen in the blood. And it could be a regular blood count. Doesn't necessarily have to be a flow cytometry compared to mycosis fungoides, for instance, that you need to have a flow cytometry, except that you have other type of cutaneous lymphoma that it could be clearly seen in a smear in the microscope. So all those things have been able to be possible due to the drive of a family member trying to understand these rare diseases. So our group is open and we are receiving members every, I would say probably maybe one every 1 or 2 weeks. Uh, but it's been active and they share their experiences as well as what the treatment has been. And the most important thing is that the members are not only from the US, we actually have members from everywhere that have been able to see this. So any advertisement for this group will be greatly appreciated, since we think we can help people and give them some guidance about what is available in the world, because again, options are very limited even in the United States. Cutaneous T-cell lymphomas and T-cell lymphomas, um, they're rare entities, and we need to come up together and collaborate in order to move the field forward. Um, one of the things that I learned in my career, this is my third year, I will say, as a faculty. However, I've been studying ATLL and HTLV1 for over a decade now. And it's something I learned by studying this rare disease, is that collaboration is essential. There is no way we could, just to put it simple, there is no way we could have come with a vaccine within a year for COVID if people wouldn't have come all together from the world and says, hey, this is a problem. We need to do something. And everyone put their heads to start publishing, learning about the virus. One group was sequencing the virus. I perfectly remember because by working in science, that's what you do. I remember one group publishing the sequence of the virus. The next group said, okay, now we have the sequence. We can use the data and start developing vaccines. Then the other group said, I can do the RNA vaccine. The other one says, I can do the live attenuated vaccines. And then a lot of people start working in the world because they saw the need of doing it. This is the same thing is for rare diseases. I cannot see myself moving the field if I wouldn't collaborate with people in Japan or people in the US or people in Latin America. When I know my casuistic, at least the number of cases I've seen in MD Anderson per year is 2 or 3 cases per year. So collaboration is essential. So whoever wants to know more about these diseases or whoever is interested in collaborating with us as a community that sees rare lymphomas, they're very welcome, but also we will be very appreciative on collaborating, since the only way to really eliminate diseases like this one, we were able to eliminate many viruses like polio, for instance. So the only way again to come out together to find ways to cure diseases, especially rare diseases, is just by collaboration. So I will call the community, doctors, no doctors, caregivers, everyone that wants to know more and wants to help, to are very welcome, since this is an unmet need. We need to come up together to fight diseases like these ones. There is certain conditions in which you can see things happening early, but also biologically being aggressive. One of the fields in which there's been a lot of work ongoing about diversity and healthcare disparities is, for example, breast cancer. So we learned that people from color has more chances of having what we call triple negative breast cancer, which is basically the most aggressive form, chemotherapy resistant breast cancer type. And at the beginning, the big question mark was always when we were seeing these worse outcomes in people from color was, is this basically driven because of the lack of literacy, lack of resources, lack of access to care? And many times the assumption was that healthcare disparities because lack of access. Until someone says, well, let me answer the question we are all guessing. Because we can all guess why something happened, but we have to prove it. And that's what science is about. We need to prove it. What at the end, what we are able to prove, or we've been proven so far, is that yes, these people lack resources, but they also have more triple negative breast cancer, which seems to be the part of being driven that. So now let's go back to lymphoma, because I gave that first example. This is what right now the ongoing research is. We're seeing disparities, we're seeing changes. I already give you example of certain diseases in which it's not about money, it's about biology. So is the biology on patient with color on CTCL differently? So that's what many people, including myself, Dr. Pamela Allen, who's been fantastic doing all this research, trying to answer. And for that, we need a lot of patients in which we can look into the human genome and try to see if there is any drivers could potentially lead that, knowing that at this moment, not much is known about which genomic drivers could potentially lead to certain things. What we have learned, for example, is patients with cutaneous T-cell lymphoma that respond to mogamulizumab at the beginning, when they lack response, one of the factors that we've seen commonly is that they acquire a mutation in the CCR4, which leads to less expression of CCR4 and therefore less response. So we don't know if that's something more frequently seen in people from color versus people from no color, and because we don't have enough studies to really prove it. But that's what we see. So is that a reason? Is a genomic feature, or in fact, it's just lack of resources and lack of access to care? However, epidemiological studies show that in fact, people from color tends to have worse outcomes than people that are white or non-black, as we call it. But the main question again comes into, is that related to resources, or that's related to biology, or maybe both? And those are things that hopefully in the next years we should be able to answer.